My name's Max Feinstein, and I'm a fourth-year anesthesiology resident at the Mount Sinai Hospital in New York City. In this video, I documented a 24-hour call that involved taking care of very sick patients, including more than one overnight emergency surgery. If you find this video interesting or helpful, I'd really appreciate it if you liked it and subscribed to the channel. Let's dive in. Usually these types of videos start off with people turning off their alarm clock and drinking coffee, but I thought, let's just get right into the exciting part and set up for the first surgery. For the first scheduled case of the day, I start the way I always start, which is going through my MS MAIDS mnemonic, which stands for machine check, suction, monitors, including a pulse oximeter, blood pressure cuff, and 5-lead EKG. A for airway, in this case I'll use a Miller 2 direct laryngoscopy blade, an endotracheal tube, which I'll make sure is styletted and test the pilot balloon. I for IV, I'm always careful to de-air my IVs just to make sure I don't cause any air emboli. And for this case I'll actually set up a second IV with a filter so that if I need to transfuse blood products, I may go ahead and do that. In terms of IV catheters, I want to make sure that I've got large bore IV access, again, just in case I need to transfuse blood products, so I'll opt for either an 18 or a 16 gauge IV, and then I'll also have a 20 gauge IV, which I'll use for my infusions. Next in the mnemonic is D for drugs. It's always important to make sure you label your syringes first before you start drawing anything up. One of the medications I'll have for this case is a depolarizing muscle relaxant called succinylcholine. And I always make sure to check the label against the vial before I draw it up, while I'm drawing it up, and then a third time after I drop the medication. In this case, I'm planning on doing a nerve block, and to accomplish that, I'll be using 0.5% bupivacaine, which I'll drop into this 10cc syringe. You'll notice that I'm using a recycling bin, so keep an eye out for a future video about sustainability efforts at Mount Sinai. One medication that I don't always drop, but will be particularly important for this specific case is nitroglycerin, which is an anti-hypertensive. This is pretty concentrated, so I'll draw it up into a diluted syringe. The end result is 40 micrograms per milliliter. The S in MS MAIDS stands for special, and in this case, one of the special pieces of equipment is an arterial line that I'll need to monitor a patient's blood pressure continuously throughout surgery. And here's a little tip for anybody who's ever set up an A-line before. Yes, it's true, the manufacturer is encouraging you to squeeze the balloon here to inflate the pressure bag. But that's definitely not the most efficient and certainly not the coolest way to fill up a pressure bag. Take your inflation balloon and notice that there's a one-way valve on the bottom of it. Let me show you a senior resident move here that you can adopt into your own practice. Go ahead and turn up your oxygen port on your ventilator to 10 or 15 liters per minute, and then you can actually place that one-way valve onto the oxygen output, and it'll fill up your pressure bag in about 10 seconds without any effort. Nice. It's especially important to de-air your arterial line to make sure you don't cause any air emboli that could lead to necrosis. Other special equipment for this case includes cerebral oximetry, and we'll also be using a bispectral index monitor to measure depth of anesthesia. In order to facilitate not only the nerve block, but also to make sure that the arterial line placement's as comfortable as possible since the patient will be awake, I'll go ahead and have an ultrasound ready to go. And since this case entails heparinizing the patient, we'll be checking ACTs throughout the case to assess just how heparinized the patient is. Next, I'll head over to the pharmacy to pick up controlled medications, including propofol, hydromorphone, remifentanil, and midazolam, and others. And this is what the completed setup looks like with 2 IVs, an arterial line, my ultrasound. And for maintenance of anesthesia, I'll have a propofol infusion, a remifentanil infusion, and a phenylephrine infusion for blood pressure support. All my airway equipment, induction medications, and the monitoring equipment that I've got set up. And of course, it's important to make sure that everybody knows who this chair belongs to, because making sure that you feel comfortable while you're at work is a vital part of well-being in anesthesiology. First case is off to an excellent start, so now it is time for the obligatory morning break. One of the benefits of training at Mount Sinai Hospital's Department of Anesthesiology in particular is that we get delicious, fresh baked bagels every single day of the week, Monday through Friday. Having grown up in Missouri, I always thought it was very silly that New Yorkers had a superiority complex about their bagels, but Now that I've been here for 4 years, I have to say, it is well deserved. Honestly, at this point, I can't enjoy a bagel unless it's fresh baked from a good bakery. Back to the OR. Keeping the wheels of the wellness train moving right along, my attending has just given me a 30-minute lunch break, which is customary in anesthesiology, and I've swung by the cafe to get myself some avocado sushi. I'm going to use this lunch break as an opportunity to answer some questions that were posed on Instagram and YouTube before I started recording this video. And please don't judge me, but for the sake of efficiency, I'm going to eat this sushi with a fork like a savage. One question I got was, how many cases do I do during a busy week? That really depends on what assignments I get. The busiest day that I can imagine having, I may have 10 or 12 cases. It's not unusual to have that type of volume in an endoscopy room or a high turnover genitourinary room where cases like circumcisions are being done. But it's also possible to just have one very long case that takes you the entire day and even takes you into the night as well. So in a given week it varies, but I'd say anywhere between 20 and 40 cases. An excellent question that came up is, what do you do if you have no clue? And the answer that we learned very early on is that you ask for help. When you need help in the operating room, that means either picking up the phone and calling your attending and or the core desk and asking for help, or if it's a real emergency and you don't have time to pick up the phone, then you ask the circulating nurse or anyone who has extra hands available to pick up the phone and call for help. A very relevant question for this video about taking 24-hour call is, how do you battle fatigue and how do you hold your focus on busy days where sleep is no option? The way that I approach this actually starts before I come in for the shift, which is making sure that I get an excellent night of sleep beforehand. Whether or not I'm on call, I always start my day having a cup of coffee, and if I'm on call and it seems like I'm going to be up all night doing a case, then I'll have another cup of coffee in the evening. But I usually don't have more than 2 cups in a 24-hour period. The question about how to keep focus touches on the actual reason that we do get so many breaks, and it's not just for our personal wellness, but has to do with being able to stay sharp and maintaining focus over a long period of time where potentially we're not actively doing something except for actively monitoring a patient's vital signs during surgery. Being able to take intermittent breaks is an important way to reset our focus, which is, I think, the reason why anesthesiologists do have a lot of breaks. But they're also excellent for our wellness. Another question that came up is, are you allowed to call out? Well, we're definitely allowed to, and in fact, we're even encouraged to call out so that we don't come to the hospital if we're sick and then get our patients sick or get our colleagues sick and cause further problems for anybody else. The case that I'm currently doing right now did involve doing a nerve block, and a question came up was, if you're left or right-handed, do you get preference in anesthesiology which side of the patient you're situated on? Generally speaking, you do get preference. That being said, I personally find that it's very important to practice doing blocks and line placement with both hands to make sure that if I'm limited in terms of my positioning ability, that I'll still be facile using my non-dominant hand. So while I am right-handed, I do frequently place lines and do blocks with my left hand just to make sure that I'm comfortable with that. And speaking of junior residents, a question that came up was, what role/relationship do you play with new residents and medical students on rotations? We very frequently have opportunities to work with medical students and junior residents, which is great not only for developing our teaching abilities, but also to just ensure that we're knowledgeable about the anesthesia and the procedures that we're doing while we're in the operating room. It's almost time for me to get back into the operating room, but first I'll answer this question of what's in your pockets. And you can see on the screen the only thing that I carry around in my actual pockets, which is a Sharpie. A little bit later today, if we have time, I'll go through what I carry around in my backpack that I have with me in the operating room. Thanks to you guys for these interesting questions, and we'll circle back to more later. And thanks to the Mount Sinai GME office for providing a generous amount of funding that bought this lunch. I'll see you in a little bit. Sometimes I get FOMO for being on a 24-hour shift and not being able to go outside, but today is certainly not one of those days. I'm actually in between cases right now, and usually the time in between cases is when anesthesiologists hurry to go as fast as they can so we don't become the reason why there's a holdup getting the next case started. but there's something else that's holding up the next case, so I've got time to go ahead and have a little snack. These Quest birthday cake bars taste like actual birthday cake, which A, I don't understand, and B, if you'd like to sponsor me, please get in touch. The one thing that I will say about expediency when finishing a surgery and getting turned over for the next case is that on rare occasion, a surgeon may remark and say, "Gosh, this 5 or 10 minute long emergence is taking a long time. Can't you hurry up?" And all I have to do is remind that surgeon that I've been waiting on what for the last 5 or 10 hours? That's right, the surgery. Fortunately, this is not really a problem that I have to deal with at Mount Sinai because the surgeons are very collegial and easy to work with. But unfortunately, I don't know that that's always true at other hospitals. All right, time to see if they're ready to get started. All right, it is now 6 o'clock and all of my scheduled cases are done for the day. Those are the ones that were electively booked. And I have just been notified that there is now an emergency case that is going to go in this operating room. So I'm going to get all set up for that and we'll get this case going. So this is basically the transition from a regular day shift to now being on call, because the on-call team is typically the team that's responsible for taking care of emergencies that come up. For the purpose of protecting patient privacy, I obviously can't say much about the nature of this case, but what I can say is that there is a failure of a very important organ, and because of that, I anticipate that there could be a significant amount of hemodynamic instability, as well as a significant amount of blood loss during the surgery. So for that reason, I'm having the blood bank prepare a significant number of blood products, and I'm also on my way to the pharmacy to pick up a large assortment of powerful vasopressors. So one really interesting aspect of being a senior resident is that as you progress through residency, more and more is expected of you in terms of being able to formulate an anesthetic plan to take care of a patient. So for this particular case, I have come up with basically the entire anesthetic plan. And of course I let my attending know what that plan is, but it feels like I could basically just be doing this myself, which is of course the goal, because in about 6 months' time, I'll have graduated from residency. As far as this particular case goes, because as I indicated, I expect that there could be a significant amount of blood loss, one of the questions that comes up in my mind is, should I get a Belmont available in the room in order to do rapid transfusion? As a general principle, I always say, if you think you might need a Belmont, you should just get a Belmont. Things are now off to an excellent start with this case. Happy to say the patient is doing well. So I have come on a little break to get some sustenance. This is the usual place where I stop while I'm on call. And it used to be that I would always give myself, some Haribo gummy bears. But I actually noticed as I was making and editing my YouTube videos and comparing myself to what I looked like a couple years ago, probably should lay off the Haribos. So now my pick-me-up of choice on call is a Schweppes Black Cherry seltzer water. Taste the cherry? Kind of. I don't know. It's fine. The emergency case is all done, and I'm happy to say the patient did very well. So I've got some time. I just had a delicious dinner, and as you'll notice, all of the food that was ordered very generously by the attending who's on overnight call is mostly chicken, but I'm vegetarian. But they did a very sweet thing and got a separate meal just for me. I've got some free time, so I'm gonna head over to the call room right now and continue answering some of the great questions that you guys asked. One of the things I've gotten in the habit of doing on call is bringing some toiletries with me so I can stay fresh. And that includes deodorant, toothpaste, and a toothbrush. So another question that was asked was, how do sleeping arrangements differ depending on how senior you are? And at least at my residency program, they don't really differ. Everybody gets a call room that has a bed, has a sink, has a bathroom nearby, and the most important thing is that all of our call rooms are individual, private call rooms. We don't have to share anything with anybody. Next question that came up was, if it's ever the Q word, what do you like to do to kill time? Obviously, I just make YouTube videos. I'm just kidding. This is not exactly the norm for what I do when I'm on call. typically I'll either just rest and relax, get some sleep, hang out with my co-residents, get some snacks, maybe do a little bit of light reading, but honestly, when you're on for 24 hours, the last thing that you want to do is study. Here's a question that is pertinent for what just happened, which is, what is it like when anesthesia gets a call from the emergency department about an emergency? So the way it works at my hospital is that the emergency department doesn't actually call anesthesiology except under the circumstance of needing help with an intubation. So if there's an emergency case that comes in through the emergency department, it's actually the surgeons who consult on the patients in the emergency department and then decide that a surgery needs to go back. So the surgeons call us to book the cases. What's that like? Well, as far as being the resident on the other end of the phone when a surgeon calls to book a case, it basically just means that you have to get all the logistics together, including the nursing staff, the operating room availability, the residents in the anesthesia department, and come up with an anesthesia plan for going back to do this emergency case. And commonly, that all needs to happen very quickly. Next up is a highly relevant question asked by a friend of mine from medical school who also decided to go into anesthesiology, and that is favorite delivery place for call. And the clear winner for me is a local Mexican joint called Sidewalk Tacos. And to be fair, their tacos are good. They're not incredible, but their churros that are cream filled are to die for. And the last of these great questions that I'll answer was also posed by a friend of mine, Andy MD, who has an amazing YouTube channel, which you can find by clicking this link right here. He asked me, what's your favorite 3 a.m. on-call snack? Andy, I have one word for you. Haribo. So at the moment, there are some scheduled cases that are still finishing up, and part of the call team's responsibility is to relieve residents from those cases, but we also have an excellent moonlighting program at the Department of Anesthesiology at Mount Sinai where we can decide to stay late if we're not on call, and then we get paid extra to do that. It's not only great for our checkbook, but it's also wonderful in terms of getting extra experience because that means you can get more procedures, see more cases, do more emergencies. So it's not uncommon for my co-residents and myself to just volunteer to stay on call to get extra money and extra experience. Anyways, in the absence of the non-call residents needing to be relieved from operating rooms, I'm just gonna go chill. Had some chill time, went to go relieve a resident from the operating room, the case ended. So now I've got some more chill time, and I thought this would be a perfect opportunity to show you what exactly I carry in my backpack. So one item that seems crucial for an anesthesiologist is an endotracheal tube, just in case there's an unanticipated emergency and I need to intubate somebody and I'm not around anesthesia equipment. Along those lines, I also carry a McGrath Mac 3. This is a video laryngoscopy device that allows me to see on screen what's on the tip of this blade. I also carry with me a Miller Tooth. This is a direct laryngoscopy device that does not use a screen. This is what this looks like. And I think it's really important to be facile with a number of different ways to intubate people. And so again, along those lines, this is a device that is called a bougie, over which an endotracheal tube can be threaded, and this facilitates intubation, particularly during difficult intubations where it's not always possible to visualize the glottic opening that you need to be able to pass the endotracheal tube. I, of course, carry a stethoscope with me if I'm not wearing it on my shoulders. I have this bag of phenylephrine, which does have an expiration date, and I do replace this pretty frequently. I'd say that I use at least a bag or two of phenylephrine basically every day. And I carry an iPhone charger with me, which is not only useful for my own phone, but also very helpful for making friends in the operating room when, say, a surgeon's phone runs out of batteries and they need to charge it. Great way to curry favor with the surgeons and the nurses. And the last thing I have in this pocket is a bag full of very small insulin needles. These are 31 gauge needles that are barely perceptible, and I use these to inject local anesthetic prior to placing IVs in many of my patients. I find that this makes for a much more pleasant experience for patients who are getting ready to undergo surgery and need an IV placed. And then in the front pocket, I have a nerve stimulator, which allows me to check twitches when I'm reversing long-acting paralysis that a patient has been given for surgery. Along the lines of reversing paralysis, I carry around several vials of a fantastic medication called Sugammadex. This is a reversal agent for vecuronium and rocuronium, rocuronium being used very commonly. I have several of these vials in here. I also have a pulse oximeter, which is very handy, particularly for transporting patients between operating rooms and recovery rooms. And the last thing I have in here is a paw tag, which accompanies the dog tag that I use to identify my bag. Kind of looks like Kobe, doesn't it? A little, if you squint. Anyways, it makes it easier for me to pick out my bag when I'm sitting next to one of my co-residents who has the same bag that was issued by the department. All right, well, it's still not quite late enough for me to go to sleep just yet, so I'm gonna go hang out with my co-residents, and then eventually we'll see what happens. I'm not gonna say it out loud. We'll just see what happens. It's a little past 10 o'clock, and just to give you a sense of what the operating rooms currently look like, you can see on the status board behind me that there is a lot of blank space, and the only operating rooms that are going are the ones that are in this blurred out box that I have right here. So we currently have 3 operating rooms going, with a 4th one about to start. And at least in my residency program, one of the benefits of being a senior resident is that the junior residents are preferentially put into emergency cases overnight. And the senior residents are available to give them breaks and staff cases if there are a lot that come up overnight, and especially to be available if there are more advanced level cases that go. So not to say that my calls are always easy, but relatively speaking, I do tend to get a lot more rest as a senior resident than I did as a junior resident. And when I'm in the operating room, that tends to be for more advanced level cases. You know, one thing that's great about being on call? The snacks, like this popcorn that's covered with caramel and chocolate. Delicious. Only on call. Well, also at home, but also on call. And I quote, "Go ask the team leader if you can help with anything. Otherwise, go to sleep." It's 11 o'clock, and that's advice that you never argue with. So, the team leader told me nothing for me to do right now, so I am gonna go try and sleep. There's actually one more doctor I need to talk with before I try and get some rest, and that is placing a dermatology consult. But not just any dermatologist. I need to call my wife, Dr. Ramia, who happened to start her own YouTube channel, which you can find right here with excellent skincare advice. And speaking of skincare advice, I probably should start carrying around some skincare products in my on-call bag so I can take better care of myself when I'm here for 24 hours. But that's for another video. Anyways, bye for now. Good morning. Just got a call about a real category 1 emergency that needs to be rest right away. So this is another case where we want a Belmont, and this is all the equipment that we need to hook up a rapid infusion catheter, which is a very large bore peripheral IV through which we can transfuse a lot of blood. Obviously I haven't had any time to have coffee, but this will certainly wake you up. Our team was able to get everything set up very quickly for this case, and we're actually just waiting on the patient to come back from a critical imaging study. Here's the equipment to insert an arterial line and a rapid infusion catheter. We have several vasopressors, including phenylephrine and norepinephrine, that are ready to go, and all of our induction medications, which notably include a syringe of vasopressin as well as a bag of epinephrine just in case. This is a forced air warming blanket, which is always important, and especially during cases where there's a lot of bleeding expected, because a cold body temperature can actually lead to more bleeding. And not shown here is a refrigerator full of blood products that we have prepared for this patient just in case transfusions are needed. Just as the sun started to rise, the day team came in and took over responsibility for this patient. I grabbed some coffee on the way out, and of course a delivery of fresh bagels indicates the start of a new day at the Mount Sinai Hospital Department of Anesthesiology. It is just past 8 o'clock in the morning, and I'm leaving the hospital a little bit later than anticipated, but that's only because we had a major case that was going, and I wanted to make sure that everything was stable and that the handoff that I made to the incoming anesthesia team was appropriate. Overall, for the 24-hour shift I did 4 cases. 2 of those were scheduled, and of those, 1 was a pretty major case. And I also participated in 2 emergency cases, both of which were pretty significant. And I was also able to get 5 hours of sleep, which is a pretty good amount of sleep, so I can't complain about that at all. And on top of that, I ate very well and had excellent company on my call shift. We had just a fantastic team. It's a pretty cold day here in New York City, so perfect for staying inside, getting warm, and since I got a full night of sleep, I'm just gonna go ahead and edit this video so I can post it soon. If you enjoyed it, check out this video that I made where I documented what it was like on my first 24-hour shift as a junior resident a couple years ago. Thanks very much for watching. I'll see you next time.